Good afternoon, everyone. Welcome to our department's citywide psychiatry grand rounds. I am Shaheen Durrani. For those that I haven't had a pleasure to meet as yet, Director of Faculty Development and Mentorship in our Department of Psychiatry at the University of Toronto. Thank you so much for joining us today. Prior to the start of our session, I would like to begin with a land acknowledgement. Before I read it, please take a moment to situate yourself and think about the land under and around you. We recognize that many Indigenous nations have long-standing relationships with the territories upon which the sites of the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississaugas and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not capture the richness of our distribution across many locations. There are few places on earth that someone before us has not called home. We are delighted today to have Dr. Eric Lenze, Professor and Chair of Psychiatry at Washington University School of Medicine, present our department's Dr. Vivian Rakoff Lectureship on the topic of managing clinical complexity in mental health services, the case of geriatric depression. Today's lecture is one of 4 named lectureships in our department honoring distinguished faculty. Dr. Vivian Rakoff had a renowned career serving as the former chair of our department as well as psychiatrist-in-chief at Sunnybrook Hospital and the Clark Institute. He was an inspiring educator who taught generations of students to incorporate humanism into the clinical care they provided. In support of continuously improving the quality of our citywide psychiatry rounds, please do complete the online evaluation that will be sent via a link from Eventbrite shortly after today's talk. Your feedback is much appreciated so we know what went well and how we can improve to better meet your needs. And please save the date for our next citywide psychiatry rounds offered as part of the department's Future of Psychotherapy conference on Friday, April 25th, 2025, where Dr. Michelle Kraske from the University of California will be talking about reward processing as a target for treatment of depression and anxiety in honor of our department's Mary Seaman named lectureship. We hope to see you there next month. So at this point, I would like to turn it over to and introduce Dr. Benoit Masson, the Labatt Family Chair of our Department of Psychiatry, to give a few remarks and introduce our speaker.
Thank you, Dr. Durrani. It is my pleasure to echo your welcome to all attendees today and to give the formal introduction of Dr. Eric Lenze. You have mentioned he's a professor and the chair or head of the Department of Psychiatry and the director of the Healthy Mind Lab at Washington University School of Medicine in St. Louis. He earned his MD degree and completed his psychiatry residency there, and he did a geriatric psychiatry fellowship and a research fellowship at the University of Pittsburgh, where I had the pleasure of meeting him and working with him more than 20 years ago. He is renowned for his research in depression, anxiety, and cognitive functioning in older adults. His research aims at reducing the negative outcome of mental illness, such as premature age-related morbidity. He has more than 350 publications published in the most prestigious journal in medicine, including JAMA, the Lancet and the New England Journal of Medicine. He's a leader in cutting-edge treatment development project. And for example, in 2020, he designed and conducted a fully remote trial that showed that the antidepressant fluvoxamine could prevent deterioration in acute COVID illness. And that paper was published in JAMA during the pandemic. And I'm now going to let him talk to us, and I look forward to his presentation and the discussion and question after. Thank you. Dr. Lenze.
Well, thank you for that really warm welcome, Dr. Mulsanne. I'm going to go ahead and share my slides here and get this slideshow started. And hopefully you are seeing my first page of my slide.
Yes, we are.
On a personal note, I may be a busy and cynical chair of psychiatry, as Dr. Mulsanne said. I have to admit, I was really looking forward to giving this lecture today. It's not often get a chance to speak to such a real center and hotbed of intellectual activity in the area of psychiatry as University of Toronto, but in particular one that I've had the great fortune and pleasure of collaborating with for about the last 20 years, including not just senior individuals such as Dr. Mulsanne and Aristotle Voinescus and Daniel Bloomberger, but also junior people who've taught me a lot, like Helena Kim and Nick Ainsworth and Peter Zukovsky. So hopefully some of you all are on this as well. This is my disclosure of interest, not a lot to report here. So let me start with what is clinical complexity, since that's in the title of my talk. What I mean by that is the complex clinical encounters we have every day. And I would posit that complexity, clinical complexity, has gone up. In fact, it's gone up a lot in a generation. And because of these changes, ours is a different field than the one I joined. And so I want to start with how and why has clinical complexity gone up? And for those of you not in geriatrics, I suspect this is something that you've noticed, whether in child psychiatry or substance use disorders or otherwise. But of course, I'll focus on geriatrics because that's my area. Psychiatric care has become more complicated because patients are presenting with more comorbidities and they're taking a lot of medications. And let's say they're self-medicating with alcohol, substances, over-the-counter meds, supplements, and the like. And then also because many treatments are now available, but a lot of these treatments are themselves complex. And in particular, choosing a treatment or a treatment strategy is complex. I've been in the field long enough to say that it used to be that there were not that many treatment choices for depression. Now look at, these are all what you might call monotherapy choices for depression. And then add to that augmentation choices. And then I would be remiss if I didn't add psychotherapy on here, which I guess I don't view as an augmentation, but something that can be either combined with or used in place of medications or somatic therapy. But in the face of all that complexity and so many treatment options, how do we choose something effective and safe? Before I can answer that, I need to go into the field that I'm in, which is geriatrics, and tell you guys how that's changed over time. For those who do not inhabit geriatrics, hopefully this will be an interesting point about longevity. What you're seeing here is a timeline of human life expectancy starting very low. Throughout most of history, life really was nasty, brutish, and short, in the words of Thomas Hobbes. And then longevity era one started in the early 1900s. And that consisted of improved perinatal care, vaccines, antibiotics, and big public health wins like sanitation and nutrition, as well as fewer accidental deaths. Well, the death rate of infants, children, and mothers especially, but really everyone, began to plummet. And so you see that line starting to go almost straight up. But then era two, longevity era two, started mid-century, and that included risk factor reduction and treatment, like smoking cessation and prevention, treatment of hypertension and high cholesterol, and people started routinely surviving into old age. I think most people would view longevity era 1 and 2 as just unvarnished goods for humanity. Then era 3 started around the 1970s with increasingly successful modern medicine techniques to keep us alive from cardiac disease, cancer, and everything else. And people have survived into very old age. Of course, I sound very optimistic, and there have been setbacks like HIV, obesity, injuries, and most recently COVID. But the overall trajectory is upward. Since the modern medicine era started, the trajectory is that killers get turned into chronic diseases that we can manage. But a problem with using modern medicine to prolong life is that advanced age comes with multimorbidity, and treating that is like what you see here, playing whack-a-mole. I assume that they have whack-a-mole in Canada. I'm going to just assume that here. What do I mean by that? What I mean is you treat cancer and there's still Alzheimer's disease, heart failure, and osteoporosis in that patient. Treat them all, and then you get polypharmacy, as each illness, each symptom gets one or more medications that are usually continued long term. So now what we're seeing with modern aging, with our third era of longevity, is a prolonged period of multimorbidity and polypharmacy, which means for you clinicians, your patients are going to have a long list of illnesses and a long list of medications. So how does that play out in terms of clinical complexity in geriatric psychiatry? Well, first of all, it plays out demographically, as you see here. These are numbers and projections from the US, where you see more and more people in the 70s and even 80s and beyond alive. But it also plays, you can think of it in terms of individual cases. 1995 was 30 years ago, was a big year for me because it was my first year in psychiatry as a resident. And in that case, in that time, this is what geriatric psychiatry looked like most of the time. I'm going to read the case out to you. 65-year-old woman presenting for depression care. She's never had mental health care. She takes no psychiatric medicines, and she only takes 3 medications overall for arthritis, hypertension, and coronary artery disease. This is a case of low complexity. Again, typical of a case we might have seen a generation ago. This is someone whose depression could be managed in a routine primary care setting. Fast forward to the present, 2025. 78-year-old woman presenting for depression care. She has heart failure, stage 3 renal disease, diabetes, hypertension. She's been hospitalized 5 times in the last year, the most recent for complications from uterine cancer surgery. She's had a stroke. She has cognitive and balance problems from that. She takes duloxetine plus bupropion. She previously took trials of venlafaxine, escitalopram, and mirtazapine. She takes 25 other medications, 6 of which are CNS active. On top of that, she takes several supplements, including melatonin. She drinks daily and uses gummies at night to sleep. This second case, more of which we see nowadays, is a case of high complexity. Treating her depression is outside of the scope of most primary physicians, and she's likely to require multiple antidepressant trials, as we'll see, to find one that's effective, and safety issues will ensue from those medications. So what do we do? Well, the first answer is research. Why? Because practitioners need evidence-based algorithms for how to treat patients. That is, they need to know what treatment to start with, when and how to switch or augment, and in what sequence. But it was not until 2001 when Dr. Mulsant and colleagues actually published the first algorithm for care. And it was realized then that we need evidence for the algorithm. The SSRIs were already being used widely at that time. But what if those don't work? And again, I'm reminding you at the bottom with that almost disclaimer, my talk is going to focus on somatic treatments, but I'm a strong believer in psychotherapy, and it fits anywhere in this algorithm. So I'm going to just take you quickly on the road to evidence-based care in late life depression. The first modern step in that road occurred about 20 to 30 years ago and is exemplified by these two studies, but also some industry-led trials. These two studies as a whole demonstrated the efficacy of SSRIs for late life depression. On the left, you see a study led by Dr. Mossant when he was at the University of Pittsburgh, where they demonstrated that an SSRI works as well, or at least I would say to my eyes, almost as well as a tricyclic. That was a huge question back then because the tricyclics were really felt to still be possibly the gold standard of antidepressant treatment, and it was unclear whether SSRIs really should be used in their place. Then on the right, what you see is an iconic study by Dr. Reynolds, Mossant, and others published in the New England Journal of Medicine in 2006, which also showed that SSRIs are effective. This was a maintenance study. So the top two lines in that survival analysis show the high rate of people staying free of recurrent depression if they stayed on their SSRI, in this case, paroxetine, including augmentation as necessary, versus the lower two lines show a rather high rate of relapse for those people who were tapered to placebo. So again, the bottom line is these two studies, as well as others, demonstrated SSRIs work in late life depression. They're effective. And because of their ease of use and good safety and tolerability, they became first line. If SSRIs don't work, what is second line? We've actually answered this, I would say, very clearly more recently with a study of 500 older adults with depression who all received a prospective trial of the SNRI, or serotonin norepinephrine reuptake inhibitor, venlafaxine. And what you see from the title of the slide is what we found. We found the remission rate with that medication in these adults with major depression was very high if the medication was first or second line, but low after that. What we did is take these 500 older adults and broke them out by how many and what kind of prior trials they had had. And so what you can see on the far left, encircled here, is if they had had no prior adequate trials of antidepressants, and then they got a trial of venlafaxine with us, the SNRI, they had a very high remission rate, almost about 67%. They also usually required a lower dose of the medication, more at what we would call an SSRI dose of the medication. Going one bar to the right, though, if you see that, you can see that if they had had one prior trial that was not an SNRI, in other words, if they had tried and failed an SSRI, or arguably the SSRI failed them, they still had a pretty high remission rate in this now second trial with venlafaxine of 47%, although it usually required a higher dose, more of an SNRI dose. Go all the way to the right bar, you see if they had had two prior trials and one already was an SNRI, they were very unlikely, less than 20% chance to remit with venlafaxine at any dose. I will add one other point to this, that this was actually led by a trainee, Erica Buchalter. She's the one who published this paper and did these analyses. And I think it really is one of the things, I'll show other examples today, that highlights the important roles of trainees and young researchers in moving the field forward. But of course, which SSRI or which SNRI do we use? Here, our knowledge as psychiatrists of these drugs is critical. Remember, we are the experts who need to know these drugs well. And to exemplify that, I'm showing you a side-by-side comparison of two SNRIs with very different profiles. On the left, amitriptyline, on the right, desvenlafaxine. Look it up, they're both called SNRIs. But based on side effects, drug interactions, off-target pharmacodynamics, active metabolites, and toxicity, in other words, based on safety, tolerability, and ease of use, you can see there that desvenlafaxine is the winner between the two of those. Again, when I was a resident, these terms like pharmacodynamics and off-target effects were not even part of a practicing psychiatrist lexicon. This is how much the field has changed in a generation, that nowadays a graduating psychiatry resident needs a working knowledge of all these issues for each of the more than 100 drugs in our armamentarium. And as a result, we tend to, in geriatrics especially, tend to avoid the drugs with more interactions and off-target effects in terms of simpler ones. So now we can start building a treatment algorithm from that knowledge and those prior clinical trials. First line, an SSRI, and again, choose a simpler one, escitalopram or sertraline. If that doesn't work, second line, use an SNRI, and again, use a desvenlafaxine or venlafaxine or duloxetine, a simpler one. But what about that third line, which is now called treatment-resistant depression, meaning that someone has failed 2 adequate trials of treatment? Then what? Well, we started trying to answer this question about 15 to even 20 years ago. And that was, first step was to test augmentation treatment for treatment-resistant late-life depression. And 10 years ago, we published this study. This was conducted at University of Toronto, University of Pittsburgh, and Washington University here in St. Louis. The first ever full-scale study of a medication for treatment-resistant depression in older adults. What you can see from the 2 figures on the left is that aripiprazole augmentation beat placebo augmentation in terms of change in depressive symptoms, and on the right, that it beat it in terms of remission rate as well. Although not shown here, we also characterized the safety of aripiprazole and found that in general it appeared to be a safe and well-tolerated option. So augmentation works. That's what that showed. But what it didn't answer is the key question, should we augment in treatment-resistant depression? After all, I was telling you about a few minutes ago about how complex these patients are. And with aging, is it possible that augmentation comes with fewer benefits, like remission from depression, and more risks, like falls and other serious risks from augmentation? So we had to do another study, and that was published more recently in the New England Journal of Medicine in 2023. Again, this was a study primarily conducted in Pittsburgh, Toronto, and Washington University, as well as Columbia University and UCLA. And this study was called the Optimum Trial, and it was a head-to-head multi-site trial that randomized over 700 older adults who all had treatment-resistant depression. And it was designed to answer the question of which antidepressant strategies are best for these older adults, meaning most effective and safest. Here's the rather complex study design we used, and I'll go through results from it. Step 1 in this, we randomized these individuals. Again, all were older adults, age 60 and up. The mean age was about 70. All had current major depression, and all were non-responders to at least 2 adequate trials of antidepressants in their current episode of depression. They were randomized, as you see here, to approximately 10 weeks of one of 3 strategies, either aripiprazole augmentation, bupropion augmentation, or a switch to bupropion. And then, not satisfied by that, we took individuals who did not improve in that first step and then re-randomized them in a second step to either augmentation with lithium or switch to nortriptyline. Recall that slide I showed you from decades ago of the study conducted by Dr. Mulsant and colleagues that showed, at least to my eyes, nortriptyline maybe being a little bit better than SSRIs. There remained a feeling that these medications like lithium and nortriptyline were oldies but goodies that still have a place in the treatment of treatment-resistant individuals. So here's what we found. Here's the results. What you see in those red boxes are the number of people who were randomized into each arm. And then I'll show you on the right the change in the primary outcome, which was psychological well-being, a combination of life satisfaction and positive affect that was actually nominated by patients themselves to be the primary outcome. And what you see is an improvement of 4.8, or about half a standard deviation with aripiprazole augmentation, about the same amount with bupropion augmentation, and a significantly lesser improvement with a switch to bupropion. In other words, and simply spoken, augmentation beats switching with respect to effectiveness. Now, we as clinicians don't generally think about improvement in psychological well-being, although our patients do. We think about remission rates. And so we looked at this way as well. What you see is a 29% remission rate with aripiprazole augmentation, 28% similar with bupropion augmentation, and a much lower with switch to bupropion. So again, by both effectiveness outcomes that I've shown you, augmentation beats switching. What about in step 2? Recall that we were thinking that these might be oldies but goodies. But here's what we found with step 2 treatments. We found approximately equal and fairly low amounts of improvement in psychological well-being or remission rate. So there was no winner among augmentation with lithium versus switch to nortriptyline, but these oldies really don't look so much like goodies anymore. I'll get back to that a little bit further in a minute. What about safety? It's really hard to come up with definitive findings about safety from clinical trials, but this was a really good opportunity to do so because we had an opportunity in this study to measure falls as a risk of depression treatment. Why? Because falls in older adults are a common and serious risk. Antidepressants are plausible culprits because they can cause orthostasis, dizziness, reduced reaction time, and a change in balance and gait. And in fact, an old study, again, 20 years ago, led again by a medical student who is now a professor at Hopkins and conducted also by Dr. Mulsant and I, found that bupropion augmentation seemed to increase the fall rate in older adults. And so we thought this might be a real opportunity, this study, to look at that, because a head-to-head comparison like this can find a fall-prone medication. And so what we did is at each study visit, we asked about falls since the last visit. And here's what we found. In aripiprazole augmentation, the fall rate was 0.33. In other words, during 10 weeks of treatment, for every 3 patients who got that there was 1 fall, which seemed like a lot. But look at this with bupropion augmentation, 0.55. In other words, a 67% higher fall rate, more than 1 in every 2 people over 10 weeks with a fall, with bupropion switch somewhere in between. So we concluded that of the 2 augmentation approaches, bupropion had a higher rate than aripiprazole augmentation. For completeness sake, I will show you the fall rates in the second step, which were pretty similar and somewhere in between. More recently, and this is a study being led by Dr. Helena Kim, a resident at University of Toronto. We wanted to ask a little bit more about the number of prior trials and whether that was affecting augmentation. Recall, I just showed you that augmentation was more effective than switch, especially in step 1. But what Dr. Kim found is that if people had failed 3 or more trials, augmentation looked effective. Less effective. What you see on the left, if people had failed 2 and only 2 previous trials, you have a pretty good improvement or change in depression score as measured by the MADRS, and a pretty good difference between augmentation and switch of approximately 3 points. But if people had failed 3 or more prior trials, the amount of improvement and the difference between augmentation and switch was reduced. So again, if your treatment-resistant depression is 3 or more trials, those augmentation options I showed you look less effective. And I would also point out that some of the key research on a next line treatment, neuromodulation, has of course come out of University of Toronto. So when you say what's next if we don't use antidepressants, TMS or transcranial magnetic stimulation has been shown effective in treatment-resistant late life depression. What you see here is a comparison of theta burst stimulation with standard stimulation in older adults with depression. And what you see down there is the remission rate. But interestingly enough, if these older adults had had 3 or more prior trials, the remission rate with TMS seemed to be lower as well at 25%. I'm going to turn a little bit to talk about service tools as well, I think reflecting the fact that this is a leadership talk. And note that there's also been important advance in evidence-based service tools. On the left, I want to remind all of you that collaborative care works. It works for late life depression. Collaborative care is a set of tools to put in the primary care setting to bring high quality mental health care into that setting to patients in that setting. And my colleague Jürgen Unitzer decades ago demonstrated collaborative care works for older adults with depression. On the right is a reminder that measurement-based care works for people with depression. This is not a study in older adults, but a study out of China from 10 years ago, which I understand was just recently replicated at the University of Toronto, which is great when studies like this are replicated because it gives them the findings more credence, demonstrating that measurement-based care, the use of measures like the PHQ-9 in your routine treatment, improves the outcomes. So now we've really gotten somewhere in evidence-based care for older adults. From decades of clinical trials and our increasing knowledge of these treatments, we can put out this evidence-based algorithm here. SSRI with specific ones preferred going first, SNRI, again, specific medications preferred going second. If those don't work, then augmentation with aripiprazole preferred because of the lower fall rate. And then after that, again, because of Dr. Helena Kim's recent findings, it's if augmentation fails and the person has had 3 failed trials, time to move to some interventional psychiatry with neuromodulation or ketamine. And then let's add the service tools to that to think through this. Those first 2 steps can be done in primary care, and they can be done well if you use collaborative care. And those second 2 steps, I would argue, need specialty care. And I would argue use algorithms like this. Your favorite algorithm might not be exactly this. You might want to use neuromodulation 3rd line instead of 4th line. But use an algorithm and use measurement-based care. They work, okay? So this is where we are after decades of hard-fought battles with research. But I want to also point people towards those declining percentage rates and ask themselves philosophically, maybe, what in fact is treatment resistance in depression? Because let's imagine that the algorithm shown here, along with those service delivery models, is implemented in its entirety, and including psychotherapy and including social supports. And then say, what if that's what depression care was like? That's possible. That's possible right now in 2025. It may be done widely in Toronto. I can tell you it's not being done widely here in St. Louis or much of the US, although we are trying very hard to get there. But imagine that this is what routine care looks like for depression. Then what's next? In other words, what's next to improve outcomes for treatment resistance? Well, I would say the answer to that depends on what treatment resistance really is. And I think one way to do that is to look at other fields for guidance. So I'm going to start by turning to infectious disease, okay, as a guidance. Infectious disease uses precision medicine, and we're being called on in psychiatry to use precision medicine, but the question is what sort of precision medicine? Shown here is an example in infectious disease of what precision medicine is. On day one, a patient shows up with a possible infection, a fever and other symptoms of infection. On that day, broad spectrum antibiotics are started, which is called empiric treatment. Empiric treatment is what we do in all of psychiatry. But at the same time, in infectious disease, a microbe culture is ordered. After day 3, the identity of that infectious agent is confirmed. And at day 4, susceptibility results return, detailing a set of appropriate antibiotics. And then the patient is changed to directed therapy, meaning the patient has this bacteria responsive to this specific antibiotic. Therefore, they will get this specific antibiotic. I would call this a lock and key type of precision medicine. Again, working with University of Toronto, we are trying to work towards that lock and key type of precision medicine in late life depression, led overall by my colleague here at WashU, Ginger Nicol, but with a host of scientists at WashU, University of Toronto, and University of Pittsburgh, and funded by the National Institute of Mental Health here. We are conducting a study called BARD, or Biotype Assigned Augmentation Approach in Resistant Depression, where we're trying to match what they do in infectious disease. Of course, we can't do a microbial culture, but what we can do is brain imaging, cognitive subtyping, clinical subtyping, blood biomarker subtyping, and genomic subtyping, and combine all that data together to create something called depression biotypes in order to predict treatment response. In other words, if your biotype is biotype 1, the data says you should receive this medication. If it's biotype 2, you should receive that medication. If it's biotype 3, you shouldn't receive one of these medications at all, but you should go directly to interventional medicine. So I'm hopeful. In fact, I'm optimistic that this kind of lock and key type view of precision medicine will advance treatment. Imagine if you are a patient and we can give you a medication that has say a 50% chance of improving your treatment-resistant depression instead of only a 29%. That's great. But I have a really sneaking suspicion that that's not the only model of treatment-resistant depression that we have to tackle in psychiatry. And so I think we need to look carefully at another field that's made some monumental advances in the area of treatment resistance, and that's cancer. Cancer is kind of like now I should say cancer has been for several decades where we would like to be now, which is that patients get good evidence-based care, and they go through algorithms, and there are good service delivery tools. And as a result of that, 90% of the mortality in cancer right now is due to treatment resistance. And so for that reason, the oncology field has focused for decades now, with a lot of money, mind you, on on treatment resistance, much more money than we've had for research in mental health. And this is what they've come up with. What they've come up with is it's very complicated, that there are many pathways by which cancer cells become treatment resistant. I'm not going to go through all those pathways, but what I point your attention to this publication at the bottom if you want to read in particular about it. But there's not one or two, but numerous pathways. And those are pathways that cancer cells can fall into at any time longitudinally in a given patient, so that they become cancer resistant. And the reason why I have a sneaking suspicion that we need to consider the cancer model of treatment resistance is because of this graphic here. This presents a picture of late life depression subtypes that's based on a lot of literature. This was published by someone who was a trainee of mine, Subramanian, and she summarized a lot of research about what we know about treatment-resistant late life depression. And it comes down to, again, this is somewhat oversimplifying it, two broad subtypes. Subtype at the top is an individual without neurocognitive comorbidity, regardless of the cause, inflammatory disease, vascular disease, Alzheimer's disease. Those individuals tend to present like a young adult with major depression. They tend to have early onset and episodic depression. Their treatment and outcome tends to be better. They tend to be more likely to respond to a treatment regardless of the treatment you choose. Their long-term prognosis tends to be better, less likely to relapse, and in particular, a low incidence of cognitive decline. Unfortunately, I think with that longevity era 3 that I described, we're getting more of those highly complex people who are in this second subtype, this more pernicious subtype, who have neurocognitive comorbidity, again, regardless of etiology. And they present differently with somatic symptoms and apathy, with co-occurring cognitive impairment, and more likely to be late onset. They are less likely to respond to treatment and have a higher incidence of dementia. And if traditional treatments, if the armamentarium we've been testing for the last 30 plus years doesn't work or stops working, or for that matter, helps symptoms but doesn't stop the accelerated cognitive decline, what's needed? Now, you might hope that I'm going to answer the question to that in the next slide, but I can tell you that we don't have an answer to that. I know that some research being led, or that has been led at University of Toronto and other places, is actively trying to answer this question. What do we do for these treatment-resistant individuals in this subtype 2? But we don't have the answers to that. But I'm going to then finish with these take-home points. There's a very pointed reason why I have the Canadian and American flags linked here, and that's because of this. I'm one of those 90% of Americans who has a very positive view of Canada. I don't know if you know this, but there was a recent poll of Americans and found 90% had a positive view of Canada. I didn't think Americans had a 90% view of anything, but then that puts Canada and Canadians somewhere in between babies laughing and free chocolate cookies in terms of positivity. But the take-home point here is that in our patients, clinical complexity increasingly predominates. So what we're going to need is findings from research. More is needed, and I'm hoping that this next generation of high-powered researchers, some of whom I've mentioned today, are going to pick up the flags, as it were, and continue with this. We're going to need more expertly trained psychiatrists who can expertly use these 100 or more treatments well, and we're going to need service tools such as collaborative care so that our patients get the best care possible. All right. I will exit here and hope that we have enough time for a really robust discussion.
Thank you so much, Dr. Lenze, for this excellent presentation and sharing your expertise in this area, reviewing how and why complexity has increased in healthcare, and sharing a treatment algorithm for caring for older adults with depression. I will now open up the Q&A and invite questions from our audience for Dr. Lenze in the Q&A box. And I see we do already have a few questions. So we have a question from James Kennedy. Has anyone checked the frequency of falls after RTMS and theta burst?
That is a really good question, which I don't think I know the answer to. I don't know if Dr. Moussant knows the answer or one of our colleagues is on. The best I can do is speculate, which is to say, I guess I don't really conceptualize those treatments as fall inducing. I've undergone not RTMS, but some TMS myself as part of some research. And my own conclusion is that it's very benign. So I would not imagine a high or any increased fall rate from it. I don't know. Dr. Moussant, are you aware of any even research on that?
I'm sure there are research on it, and Dr. Bloomberger could give us the answer, but I don't know. I'm like you, I don't know it. What the audience need to know is depression in late life by itself increases the incidence of fall. So it's a complex interaction between the disease and the treatment.
Yeah, the fall rate won't be zero because the, let's call it natural fall rate in older adults is, it is whatever it is. We generally quote 1 out of 3 per year, but those are old data. And I'm not sure, an old study by Mary Tinetti, which is very famous, but you could ask whether it applies to today's older adults or not.
Wonderful, thank you. So we have another question from Daniel Mueller, and he thanks you for your great presentation. His question is, how do you think these presented findings relate to adult psychiatry? In other words, are there unique factors in late life depression determining response and side effects compared to adult psychiatry based on perhaps data, observations, or your personal opinion?
Yeah, that's a terrific question, Dr. Mueller. And again, another person who I've had the great fortune of collaborating with over the years with Dr. Mueller and some of his really excellent trainees and younger colleagues. But 2 answers to that, I would say. One is what I showed in that picture of the 2 subtypes. We believe that within all older adults with depression, again, I'm speaking very kind of almost impressionistically, that there's a subtype of people who are more or less the same thing as a younger adult depression. They just happen to be older. But then there are people with more of a real geriatric or aging specific subtype. They have aging-related brain disease. They have aging-related frailty, and that they have a fundamentally different outcome, and in many cases may have a fundamentally different disease. Okay. The second thing regards safety, that with aging becomes less resilience. I think any of us over the age of 50 innately knows that, but if you're age 30 listening in, that's what you got to look forward to. But there's just less resilience to just about anything, frankly, anything physiological, which means less resilience to effects of antidepressants and other psychiatric drugs. Another way of putting it is, I don't think bupropion augmentation causes falls in younger adults. At least I've never heard of that. And when I show these findings to adult psychiatrists, they're actually genuinely perplexed by them because they've never heard of that.
Thank you for that. So we have another question from Mark Rappaport. Mark Rappaport is our program director for the geriatric psychiatry subspecialty program. So his question is, in your view, can you elaborate on the role lithium augmentation plays in treatment-resistant depression in older adults, given the recent findings and algorithm?
Well, that's a great question. Thank you, Dr. Rappaport, for that question. And I don't know if I'll change anyone's opinion if people have strong positive opinions about lithium augmentation. The research may not change that opinion, but the findings are the findings here. In other words, we found a front runner for augmentation. So after two failed monotherapy trials, aripiprazole augmentation is evidence-based and looks good safety-wise compared to other options that we tested. But then what? You might think lithium augmentation after that, but our own data from Optimum suggests there's not a lot of chance that that's going to help. That doesn't mean don't ever use it, but it just means that well, once upon a time I might have tried 3, 4, 5 different augmentation trials before moving to ketamine or neuromodulation. Now, based on the Optimum findings, and in particular, Dr. Kim's reanalysis of those findings, I'm much more inclined that if someone has failed one augmentation trial, I'm ready to move on to interventional psychiatry.
So we have another question from Rob Madden. He asks, is there any evidence that doing pharmacogenetic testing for treatment-resistant situations results in better outcomes?
Yeah, that's a really great question, and I didn't get into pharmacogenetics in this because it's its own whole presentation by itself. I think Dr. Mueller or Kennedy would be better at giving that talk anyway. I guess I would say this: there is some evidence about that, right, from an industry-led study. I guess the findings were a little bit mixed from that study, but optimistically, you could say that it showed some evidence of that. But I would say this: in geriatric psychiatry, we tend to favor drugs that avoid the kind of drug-drug interactions or cytochrome P450 effects that you would be informed by pharmacogenetics anyway. In other words, if you're using escitalopram to treat someone, and then let's say desvenlafaxine, and then aripiprazole after that, it really doesn't matter if they're a cytochrome 2D6 poor metabolizer or not. Other medications, it may matter a great deal, but for those, it really does not matter. So I tend to use drugs that are simpler, and therefore I tend not to use or find benefit from pharmacogenetic tests.
Thank you. So we have a question from Harold Pivko. How much of treatment-resistant depression in geriatrics might be considered a form of conversion disorder, in which case the treatment strategy would be different? Also, treatment-resistant depression is often a reflection of trauma and shame. So curious to know your thoughts on this. And Harold is also asking about the survey that says Americans like Canadians, and if you could share the reference for that.
Yeah, the survey was just done in February, so I don't know if I will be able to dig it up in live while doing that, but I will look for it. But the comparing it to babies laughing is my own elaboration of it, though. I guess I have not heard of the example of conversion disorder, and so but what I would say, as far as the second part of what you say, a reflection of trauma, shame, what I would say about this is our definition right now of treatment-resistant depression is quite biologically reductionistic, right? To take, say, an individual who is doing well on their antidepressant and then suffered, let's say, intimate partner violence and has a relapse of depression, and to put them into the same category as someone who, for some, really, it feels like biologic reason, just did not budge when you tried antidepressants in terms of their depression. It's very reductionistic, and I freely admit that. I think it'll be really important to include psychosocial measures, including trauma and psychological measures in our understanding of treatment-resistant depression and who responds to what. And again, I continue to be a strong believer in psychotherapy as something that works well at any place in that algorithm.
Thank you. So another question from Paul Verhoff. Besides fall rates, if one would look at discontinuation due to any adverse effect attributed to the antidepressant, how did the switching and augmentation strategies of the Optimum study and other studies compare?
That is a great question, Dr. Verhoff. And if you dig into the New England Journal article, we actually have all those results in there. We have adverse effect data or adverse event data. We have serious adverse event data. We also have discontinuation related to adverse event data in the with the antidepressant. But what I will say is that it's a little bit more complex than that. When a patient discontinues a medication, it's probably, even if they say it's due to side effects, it's often due to a mix of things, right? Because if you are really strongly believing in a medication and that it's helping you, you may tolerate, you may be willing to put up with some side effects. But if you really don't believe in that medication, either because you just don't believe in it, or because it doesn't seem to be helping you for it, even mild side effects might be enough to make you, or even your perception of side effects might be enough to lead you to discontinue it. What I can tell you, interestingly, going back to that augmentation versus switch in step one, we looked at the data a little bit different way, and we said, what percentage of people actually remained on the strategy and remitted? In other words, at the end of 10 weeks, were they still on that strategy, or did they or their clinician give up on it? And had they remitted? And the delineation between augmentation and switch widens, actually. 25% of people who were started on, or who were randomized, I should say, to aripiprazole augmentation finished out the end of that step, still on aripiprazole augmentation and in remission. That doesn't maybe sound great, 25%, but with the bupropion switch, it was less than 10%. I think it was like 9.8% remained on that bupropion switch and in remission. So when you start to look at the data in the way you're describing there, then some of these approaches like bupropion switch, and I'll add lithium augmentation, start to look really futile. It's in the paper. You do have to look a little bit for it, but it's a great question. Thank you.
Thank you. And we'll maybe have time for one more question. So from Zaid Ghazala, given the recent findings, what is the current role rank of ECT in managing treatment-resistant depression?
Yeah, I'm also a strong believer in ECT, and I think it has a very important role. I view the problems with it, especially as the neuromodulation or ECT experts have continued to refine ECT, making it more and more well tolerated, particularly with respect to the cognitive side effects. I view the main problems with ECT as these. One is logistical, right? Logistic problems. You have to, A, convince a patient to get ECT, which still has tremendous stigma. And then they have to undergo a medical procedure with general anesthesia and all that entails, 3 times a week, I have to say, sometimes a pill or TMS or ketamine is just easier and more acceptable to patients. And then the other problem I see with ECT, similar to TMS, is with respect to maintaining response after someone has responded to an acute course of ECT. Now, fortunately, there is some maintenance data now with ECT, but I think we still fully don't know how to keep people well after they've gotten well with ECT.
Well, thank you so much, Dr. Lenze, for your very informative presentation and sharing your expertise on the treatment of depression in older adults. We're very grateful for your commitment to advancing care for this patient population. Thank you as well to our support team, Anne-Marie and Matt, for your help behind the scenes for today's rounds. And finally, thank you to our attendees for joining today's session and for your engagement and participation in the Q&A. We look forward to seeing you at our next citywide psychiatry grand rounds on April 25th on reward processing as a target for treatment of depression and anxiety. Enjoy the rest of the day, everyone.